Okay, so now we've discussed vasodilators, including ACE inhibitors and ARBs, as well as hydralazine and isosorbide dinitrate. And so now we're going to focus on using beta blockers in the context of treating heart failure. And so understand that beta blockers all have the suffix LOL, not laughing out loud, but LOL. And that's an easy way to remember or to recognize them by their name. So understand that autonomic nerve impulses drive a lot of the heart processes. And so you can find the beta-1 receptor on pretty much all cardiac tissue, from the SA node all the way down through the conduction cells and fibers into the ventricular muscle. And so all of what we think about cardiac function is really kind of driven by, excuse me, the beta-1 receptor. So it'll, when stimulated with norepinephrine, it'll increase heart rate at the SA node. It'll increase conduction velocity and contractility within the atrium. And it'll increase the rate of automaticity within the AV node. And the same carries through as you progress down the list. The way in which this works is that essentially norepinephrine or epinephrine bind to the beta-1 receptor on the cardiac cell, okay, and that basically stimulates the activity of the enzyme adenyl cyclase, okay, which causes an increase in cyclic AMP. That cyclic AMP opens up the calcium receptors, which basically increase the amount of intracellular calcium within the cardiac myocyte, and more calcium translates to a stronger, more intense muscle contraction. And so this is really kind of the normal physiology of how these beta-1 receptors operate. Understand that cardiac function is comprised of many facets that are kind of under autonomic and both hormonal control. And basically that the thing that really kind of drives the pathophysiology is really changes to this process. And so I really like this diagram when you look at the activity of beta receptors and what it means to supply a patient with a beta blocker. So you can kind of insert a beta blocker into this paradigm and you can kind of see the compensatory changes that are going to occur both at the heart level, but as well as the systemic level as well. And so this is kind of a nice concept map that kind of puts cardiac physiology in kind of a larger picture. So what we talked about is normal beta-1 mechanisms in terms of how beta-1 drives cardiac contractility, heart rate, both of which, when increased, will increase cardiac output. But in this particular patient, we said there was low cardiac output, right, as evidenced by a reduced left ventricle ejection fraction less than 40%. And so we're going to supply beta-1 antagonists. And so one thing to keep in mind is that, you know, these descriptors in terms of what you're going to see in the next few slides are really important in terms of understanding how these drugs work, because there are some drugs some beta blockers that are non-selective. So they inhibit or antagonize both the beta-1 receptor and the beta-2 receptor. And we'll talk about the beta-2 receptor in the context of asthma and COPD, but understand that for the heart failure patient, we're really only using a select few number of beta blockers, 4 in fact, which have been proven to be clinically effective, and they all essentially have most affinity in terms of the beta-1 receptor. And so the two beta-1 blockers that you should be aware of is Metoprolol and Bisoprolol. So these are beta-1 specific antagonists. Okay, they have relatively no selectivity to the beta-2 receptor, which is both therapeutically beneficial and clinically relevant. And then there's another class of compounds called mixed-acting beta blockers, and so they are technically beta blockers. They block the beta-1 receptor, but they also have some inhibitory effect on the alpha-1 receptor. And we'll talk about the clinical usefulness of this particular drug, carbidiol. So the prototype beta-1 blocker is metoprolol. Mechanistically, it's going to bind to the beta-1 receptor on the heart, and it's going to compete with that receptor for norepinephrine. And the resulting physiological outcome is going to be a dramatic reduction in myocardial oxygen consumption. Okay, and so the rationale for that is that inhibiting the beta-1 receptor produces a negative chronotropic effect. Okay, and that is seen during periods of stress or heightened activity such as exercise. And so that's going to produce a reduction in arterial blood pressure. It's also a negative inotrope, and so there's going to be a reduction in contractility. Okay, so we can use beta blockers in a whole host of cardiac pathologies, from unstable angina to the post-myocardial infarct patient, as well as this patient, which has systolic heart failure. It's been shown time and time again that when you supply beta blockers to these patients, you see reduced morbidity and reduced mortality rates across the board. So these are very clinically useful, medically necessary drugs for these patients. Okay. Now it's interesting, if you look at the historical guidelines, and we'll mention this a little bit later, beta blockers were actually once contraindicated in heart failure, and you'll see why. In 2013, the American College of Cardiology demonstrated that beta blocker therapy, with one of the 3 proven beta blockers that are shown to reduce mortality in patients that had current or previous symptoms with heart failure, fared much better. And so, there's a whole host of different recommendations and guidelines and so forth that have come out. And so the take-home message here is that while these beta blockers are very, very useful for these patients, there is some little bit of caution when starting beta blockers. And we always start with the lowest possible dose and increase incrementally as needed based on how the patient is doing. So it's not like you just give a blind dose. We always start low and titrate accordingly. So the beta-1 selective antagonist, or the beta-1 selective blocker that we should be most aware of is metoprolol. It comes in 2 different formulations, a tartrate, which is an immediate release preparation, which is typically given 2 to 4 times a day, and a succinate, which is kind of an extended release preparation, and it only requires once or maybe even twice daily dosing. The succinate formulation of metoprolol has been clinically favored in heart failure time and time again. So you typically see succinate used in the heart failure patient. Bisoprolol is also quite potent, and it only requires once daily dosing. And really it's the dosing frequency that's really kind of distinguishes these 2 drugs. Metoprolol, as we said before, is very cardioselective. It's 50 to 100 times more selective to the beta-1 receptor, which is found exclusively on the heart, than the beta-2 receptor, which is found in smooth muscle. Metoprolol is nonpolar, so it can enter the brain, and it's also associated with the common side effects of nightmares and depression. And contrary to popular belief, it can still be used in mild asthmatics and diabetics, and that's because there's very little beta-2 mediated selectivity. So there's very little bronchospasm. It has practically little to no effect on insulin. Of course, those 2 processes are driven by the beta-2 receptor. And there's also a membrane stabilizing type of compound, which is interesting in terms of other heart pathologies, including arrhythmias, because it looks like metoprolol can inhibit sodium channel activity as well. And so we call that particular ability to be membrane stabilizing, and we'll learn about that in another module. And so the clinical trials that are associated with metoprolol use in the context of heart failure are indicated there for historical reporting. The other drug, bisoprolol, is very potent. It's very similar to metoprolol. It has both renal and liver elimination, and it's been typically used for chronic hypertension and heart failure. And the clinical trials are listed there as well. Okay, so understand that when you have beta-1 antagonism, we produce negative chronotropy, so we see a decrease in heart rate, we see a decrease in stroke volume. It's negative inotrope, so we see a decrease in contractility. It reduces cardiac output, and it also has renal effects. And that's because there's a beta-1 receptor on the juxtaglomerular cells, and when you inhibit that receptor, you inhibit the renin secretion that would have been enhanced by norepinephrine binding. Okay. Side effects and toxicities with beta blockers include bradycardia and hypertension. And in some patients, you can see an exacerbation of heart failure in 2 to 6 weeks.